All right. Hello, everyone. My name is Olivia Jacquemart. I am a mental health trainer team lead, and today I will be guiding you through the Understanding Dementia for the IDD population training. So first, we're going to have to know what our objectives are for this training. So we want to be able to identify some of the common signs and symptoms of depression, anxiety, and dementia, identify those behaviors that are common with dementia, as well as identify the needs of clients with dementia, as well as put those potential triggers for behaviors. So these are going to include those environmental triggers, any kind of interactions, and just other things to be aware of when it comes to those patient-specific triggers as well. So we are going to be going through some of the general things to expect when it comes to aging in the IDD population, just kind of as a general rule as well. So first and foremost, looking at the life expectancy. In the early 1900s, the average life expectancy for someone with IDD was as low as 19 years old. Coming into today, the average has risen to about 70 years instead. For example, the life expectancy of individuals with Down syndrome has significantly improved, increasing from around 50 to around 70 years in just recent decades. Much of this shift is attributed to increased literature and research, improved healthcare systems, and enhanced social services that support individuals with IDD across their life course. Although substantial strides have been made towards greater longevity, life expectancy is still behind the general population by a rate of 7 to 8 years. This is often due to underlying health conditions, economic and social disparities older adults with IDD experience just throughout their lifetime. People with IDD tend to experience an accelerated aging as a result of chromosomal or other developmental abnormalities. This means that age-related conditions and functional declines occur earlier and progress more rapidly than in the general population. Individuals with lifelong disabilities often face increased risks of health disparities and early onset of age-related conditions such as dementia, increased heart and kidney disease, and others. So individuals with certain disabilities may also experience accelerated musculoskeletal changes, leading to earlier onset of arthritis and mobility limitations, further increasing fall risk. These age-related changes may be seen as early as 45 to 55 years old for individuals with IDD. For the general population, these age-related changes start to be seen around 65 to 70. By age 60, about 1 in every 16 adults with an IDD will be affected by some form of dementia. This rate continues to increase as the population ages as well. Evidence suggests that the prevalence of dementia in those with IDD, especially Down syndrome, is higher than those without the IDD diagnosis and may develop at those younger ages. The average age of onset for dementia for adults with IDD is in the late 60s. However, the average age of onset for adults with Down syndrome can be as early as 35. It is estimated that at least half of all people with Down syndrome who live into their 60s will develop some form of Alzheimer's or dementia. Risk factors for dementia includes age, family history, high blood pressure, high cholesterol, diabetes, and multiple medication use. The recommended age to begin dementia screening is 50 in adults with IDD and around age 40 for adults with Down syndrome. And as direct support for our individuals, we are often working with many people involved with our individuals' care. This includes primary caregivers and guardians. The aging of IDD has a distinct effect on their caregivers, many of whom are aging themselves. This concurrent aging may present unique challenges for individuals and their caregivers, 75% of whom are parents and step-parents, with more than a quarter over the age of 65. Most caregivers, around 70%, also tend to live with the person for whom they provide care. Tradition is often seeing adult children caring for their aging parents, where in our individuals with IDD, there's a reverse dynamic happening, where these aging parents continue to provide lifelong care. Caregivers overwhelmingly want their children or siblings aging with IDD to have quality, safe, fulfilling lives once they're no longer able to provide care due to their own concurrent aging. With our support, hopefully we can continue to assist and refer to other resources to give our individuals the best quality of life possible. Now getting into the specifics on dementia and what to look for. I want to highlight some statistics here for us. So about 6 million Americans suffer from dementia. Then about 42% of individuals who are 55 or older will eventually develop dementia in the US. That's almost half of all adults 55 and older will eventually develop dementia. Dementia cases account for 100,000 deaths a year in the US. With the aging population becoming older and older, by 2060, there's an expectation for dementia cases in the US to double, hitting nearly 12 million cases. So we need to understand dementia in order to provide the best quality of care possible. First, dementia is not a specific disease. It is a group of symptoms that indicate there is damage in parts of the brain that control memory, reasoning, judgment, and eventually bodily functions. Then dementia tends to be progressive in nature. This means that symptoms are going to start out slow or mild, and then they're worsening over time, leading to cognitive impairment. As someone starts to develop dementia symptoms, there are literal changes to the brain occurring. Actual damage is happening. Things such as short-term memory loss, decline in thinking skills, and behavioral changes are all impacted and can impair daily functioning in an individual's life. Dementia can also change an individual's ability to regulate their emotions, as well as have their personality affected. Here are the 5 signs and symptoms that may occur in patients who are experiencing dementia. Each of these A's alters the individual's quality of life in some form or manner. So we're going to go through agnosia, amnesia, anomia, aphasia, and apraxia. We're going to dive into each one of those. So agnosia is a neurological condition that results in an individual's inability to recognize common objects. Things such as car keys or an apple, things that may have been very commonplace. It could be that they're also having an inability to recognize people, smells, and or sounds, despite their senses functioning in a normal capacity. Furthermore, this inability to recall is not due to the memory loss, just an inability to recognize. Next is amnesia. This refers to the loss of memory, such as facts, information, and experiences. What is important to note is that amnesia is not dementia. It is just one aspect of the overall condition. So it also includes trouble learning and retaining new information. The most recent memories are likely going to be lost first, with trouble remembering any kind of recent experiences. And amnesia does not affect intelligence, judgment, personality, or identity. So long-term memory is the last to go because these memories are well stored in the brain. A person with dementia may be able to describe aspects of their earlier life, such as schooling or childhood, but not remember what they did an hour ago. For the person with dementia, the past is their present. However, long-term memories are not always reliable, so what is remembered may not always be exactly what happened. As dementia progresses, even memories from long ago do tend to be lost. Some common symptoms that come from amnesia include being disoriented, the inability to recognize those faces or places, having uncoordinated movements and confusion, having partial or total memory loss with those potential false memories. So, music can trigger memories and provide comfort for individuals with amnesia, even when other memories are lost. Musical memories are actually stored in different brain regions than other memories. Here's going to be a short video identifying the benefits of behavior modification that music can have on patients who have dementia.
program that we're trialling at Laurelton is an evidence-based program. It's from Stanford University, who were researching the effect of music on the brain and developed some principles around how you use music to stimulate memory function, social interaction, engagement, and also a sort of soothing element as well for people with advanced dementia.
The first time I did with Deb, I saw her walking around lost, like she's by herself. I hold her hand and I showed this and I put it in myself. I got her attention. What is this for? She will giggle. It makes us so happy to make her feel that she got her own world that she enjoyed.
He has a lot of different behaviours, Eric. He becomes very agitated at times. He's very fidgety, where he's into other people's things. He's very hard to communicate with at times. If we get the music and he sits down, sort of just becomes a calmer person, and he sits there.
Yeah, well, if there wouldn't have been anyone there.
Smiling, interacts more with us.
I love this song.
You love this song? Later, he's very calm.
We actually see this program as being a very important part of relationship-based care. And that's because getting to those pieces of music that really have that positive effect and that really matter to that person are all part of that process of really getting to know someone well. It just adds to another level and richness to that understanding about that individual.
So we are now going to move into anomia. Anomia is characterized by having trouble with words. So there are issues with finding the correct word when speaking or writing, and there's that feeling of, ooh, it is on the tip of my tongue. So this is on the earliest and most common symptoms with dementia patients. Because of this, individuals with anomia may take longer to convey their thoughts and feelings, and being patient with your individuals is imperative, especially when they're dealing with anomia. And individuals with dementia often have those language difficulties. Aphasia is the inability of a person to understand speech and or to produce understandable speech. It is seen in people who have had strokes that affect the language section of the brain, and it is also seen in dementia when the language center of the brain becomes affected. Individuals with aphasia may have no idea what is being said to them. It's really as if you are speaking a foreign language. In other instances, individuals may understand what is said, but cannot produce the speech themselves. They either cannot remember the right word or jumble their words, and it may be difficult or even impossible to understand. With apraxia, individuals can no longer perform common tasks that were once thought to be routine. The inability to perform tasks that have been long pre-programmed is eventually erased in dementia, sometimes with strokes and other forms of brain damage. Performing what were once daily tasks just becomes too complicated for the person with dementia. Apraxia differs from normal aging in that it involves a loss in planned, purposeful movements, despite intact muscles, comprehension, and sensation. Normal aging produces slow, gradual declines, whereas apraxia has specific and inconsistent errors. Apraxia is a neurological disorder resulting from brain damage, such as dementia. And lastly, we have agitation. So agitation can occur when any one of these 5 A's are present, and is more likely when a combination of the 5 A's is present. Agitation really can be thought of as the 6th A of dementia. So when individuals with dementia have discomfort or cannot understand or tolerate things going on in their environment, they may become anxious and display signs of agitation. A feeling of being uncomfortable and anxious is a common response for all of us when we are confused, fearful, or feel as though we have little control over what is happening to us. So, for a person with dementia, this is often shown in physical behaviors, such as being jittery, very nervous, aimlessly pacing, or other behaviors indicating emotional discomfort. So, let's discuss some behavioral symptoms of dementia. There are several behaviors that are common amongst individuals with dementia. Memory problems and subtle behavioral changes are evident in early dementia, while many of the more overt behaviors are going to occur in persons with moderate to severe cognitive impairment, those later or more advanced dementia symptoms. So, how common are behavioral symptoms of dementia? Well, every person with dementia will display some of these common behavioral symptoms. The common behaviors are ones like forgetfulness, the repetition, whether it is repeating words, questions, or repeating actions, wandering and sundowning. More challenging behaviors can also occur, such as screaming, cursing, paranoid accusations, and name calling. About 45% of people with dementia may display harmful behaviors, things such as hitting, pushing, or biting at some point in the disease. When it comes to identifying triggering behavioral symptoms, you are in the best position. So you should be the detective. You are with these clients consistently and you know them well. So make sure to always look for what is causing or triggering the behaviors. Behaviors are often triggered by physical needs of the individual. So it could be that they're hungry, they need to use the restroom, or environmental events, things that are loud or excessive noise, any kind of diminished light or staff changes. These triggers may be a clue to the appropriate intervention. When you figure out what caused a behavior, you have a better chance of finding an effective approach to addressing the behavior and preventing future episodes. Each behavior may have a different cause and may need to be addressed in different ways. It is important, therefore, to assess each behavior individually and establish a plan for addressing each unique behavior. If it's too bright in the room, turn off a light. If someone is hungry or thirsty, provide them with a snack or water. Knowing the person's previous behavior and how they coped may help you to better understand the current behavior. First, we need to describe the problem behavior. What is the real concern? And make sure to look at it carefully. It's not enough to say he's agitated or he's confused. The behavior must be evaluated in terms of possible causes, potential for danger to self or others, and for whom the behavior is actually a problem. Is it a problem for the client themselves, the staff, or maybe family? If the person has recently moved or changed rooms, it may take a couple of weeks before behaviors can be adequately assessed. Changes such as moves can either result in past behavior stopping for a time or new behavior surfacing. Eventually, typical behavioral patterns will emerge and can be assessed. If a trigger is identified, try to modify the triggering event. Validate what the person is saying by acknowledging the feeling behind the verbalization. Be with the person where they are. Remember, if they are stating they need to go to work, don't argue with them. Remember, their past is their present. So ask them about their work and what they like most about it. Do not tell them they no longer work. This is only going to increase some of that agitation. They are living in the past, and that is what is real to them. So ask them, what about your work do you like? Sometimes it's also helpful to tell some of those therapeutic lies and let them know, oh, it's a holiday today. You don't need to go in. So by slowly changing the subject of going to work, you can divert the person's attention and redirect their attention to other activities. If an underlying cause is not found, then giving a person significant attention only when they're displaying undesirable behaviors may actually reinforce the behavior you don't want them engaging in. So it may be better to ignore inappropriate behavior or walk away from the individual if it is safe to do so. Then you can address appropriate behaviors and give attention and positive reinforcement during appropriate behaviors. Just make sure to be tolerant of a behavior if it is not posing any safety risks. As we move on in this training, we will discuss the common triggers and behaviors and what may be some of those underlying causes. So first, looking at wandering. So wandering can be broken down into the following categories. First, orbiting. So this is when individuals start at one point and return to the same area. They literally seem to be orbiting around this one central location. And then there's visiting. So some people, when wandering, will tend to enter other people's rooms as part of wandering behaviors. And then shadowing. So as the name is indicating, this is when an individual follows closely behind another individual. And then rummaging and hoarding. So some individuals with dementia tend to rummage through drawers and closets as if they're looking for something. And then others tend to gather up all sorts of items as if they were collectors. And then repetitive behaviors. So repeating the same phrase, activity, or emotion repeatedly. These behaviors can often be annoying and frustrating for caregivers. And continual pacing is seen when a person is walking aimlessly back and forth. Fidgeting is also common with individuals being in seemingly perpetual movement. Maybe they're twisting a piece of clothing, constantly moving in their chairs, moving their feet, anything like that. Some repetitive behaviors appear to be attempts at self-soothing. If the individual does not appear distressed, other clients are not adversely affected by the behavior, and it does not jeopardize anyone's safety, it may be best to just tolerate those behaviors that are occurring. There are going to be several triggers for wandering, elopement, rummaging, and those repetitive behaviors. There could be that it's the time of day or sundowning. It could be discomfort, confusion, fear, and just boredom. There are some cases in which a trigger may not be easily identifiable, and the behavior seems to have no apparent cause. Wandering, pacing, and fidgeting are not necessarily bad behaviors because they do provide physical exercise and possible social interaction. However, they may be annoying to staff and other individuals. So make sure to assess what is actually a safety concern and what should be tolerated. So individuals with dementia may wander at any time of the day, but for many, evenings and nights are times when behaviors are likely going to become worse. Toward evening, some clients become more agitated, confused, and exhibit that wandering behavior. This is often referred to as sundowning. We don't know for certain what causes sundowning, but it may be triggered by some biological changes in the person, such as disruption to the person's natural sleep cycle or the way the brain processes light. Things that appear to make the condition worse are tiredness at the end of a long day, confusion or fear caused by shadows and dim light, or too much or too little stimulation. Not being able to see or hear well also seems to aggravate this condition. So there are common verbal behaviors. These can either be aggressive or non-aggressive. Non-aggressive verbal behaviors can include repeating questions and comments, which often occurs because the individual does not remember what they just said. It can become frustrating for caregivers when they're asked, "What time is it?" several times within a minute, but it does no good to become impatient or scold the person. It's not going to help them remember that they said it already. And then constant repetition of the same word or phrase tends to occur in later stages of dementia, where they literally get stuck on a word or phrase and can't seem to move to a different phrase or activity. We also tend to see some babbling, some screaming, or even moaning. However, with aggressive behaviors, we can see things like cursing, sexual or racial slurs, and name calling. These can be quite distressing for family, particularly if the person was typically reserved and never spoke harshly to or about others. They can also be difficult for staff when the names or slurs are directed at them. Behaviors associated with dementia can be triggered by physical or emotional conditions in the individual. These are some of the common triggers for any verbal behavior. Things such as the personal discomfort. So maybe someone has soiled underwear and needs hygiene tasks taken care of. Maybe they're in an uncomfortable position, so they're really sore. Maybe they're hungry or thirsty and need something biologically. It could also be that they're having anxiety, an illness, such as a UTI, causing further confusion, as well as any kind of fear. Individuals that have ongoing dementia may be experiencing things like delusions or hallucinations, which increases that fear and anxiety. Additional causes and triggers may be the memory loss, where the individual cannot remember what was just said or done, any kind of boredom, so there's a lack of engagement or stimulation, just frustration, so the individual can be in need for validation, changes in the environment or routine, unexpected noises, a large number of people, and any kind of other distressing behaviors from others. And those physical aggressive behaviors. This can be hitting, biting, kicking, pushing, or spitting. It is estimated that physical aggression occurs with about 45 to 50% of people with dementia at some point. It is most likely to occur when the individual is frustrated, pressured to do things that they no longer can do, or they're just really tired. Physical aggression needs to be managed for the safety of the individual themselves, other individuals in the area, and staff. Physical aggression can be disturbing to staff and other clients, especially when it seems like the opposite of who that person used to be. Remember, individuals with dementia often have little control over their behavior. The area of the brain that helps us control our behavior is often damaged as dementia progresses. Never take the behavior personally, as these behaviors are due to the damages occurring in the brain. Even if it is totally out of character, we cannot take that behavior personally and assess the triggers that may be causing the behavior. Preventing behaviors from escalating and becoming aggressive requires a calm, reassuring approach. It is important to quickly assess the cause of the behavior so we can accurately consider the safety of yourself, others, and the individual. Lastly, we have those inappropriate behaviors. These are behaviors that tend to make others uncomfortable. They include behaviors such as sexually explicit language, disrobing or urinating in public, touching another person or oneself in an inappropriate area of the body, getting in bed with another person without mutual consent, and even pleasuring themselves in public. Inappropriate behavior is often most difficult for family and caregivers, as the behavior can appear to have those sexual overtones. Some of these behaviors occur due to the area of the brain affected by dementia. Many, though appearing to be sexual in nature, are not, as others are the results of biological needs that the individual can no longer control. And it must be remembered that these behaviors are rarely intentional on the part of the individual with dementia and are the result of damage to the area of the brain that controls inhibitions. Individuals often do not comprehend what they're saying or doing and how their behavior is actually being interpreted by others. There could be underlying problems that are not related to any sexual intentions causing the behavior. And rarely do these behaviors lead to actual sexual assault, but they can be highly embarrassing to other people, staff, and visitors. So lastly, we're going to discuss what strategies may work to reduce or eliminate behaviors when necessary. So the best way to manage behaviors is to prevent them. The way you communicate can help an individual calm or can make the difference between calming a distressed individual or causing an escalation of the behavior. Navigating conversations with someone with memory loss requires extra time and patience. Calling the person by name and being at eye level will be less threatening and show care and respect. Studies have shown that individuals are more likely to respond negatively when spoken to in elder speak. This is referring to speaking to older adults as a child or addressing them with words that are meant to be endearing, such as sweetie, honey, girly, dear. You want to avoid using these terms and just refer to the individual by their preferred name. Always speak in a low, calm, and reassuring manner, and make certain that your nonverbal behavior is also reassuring. Clients who are displaying behavioral symptoms of dementia are often frightened, confused, or frustrated. And if you display irritation or attempt to pressure them or force them to do an activity, they will be further threatened, and the unwanted behavior is likely to escalate. It is also important to give the client time to respond. The damage in the brain caused by dementia results in information being received and processed more slowly. Rushing the person may result in added confusion and frustration. Persons with dementia have a difficult time remembering what they are trying to communicate without any interruptions. If interrupted, they are likely to become more confused or agitated. Make sure to never interrupt and respect the conversation, regardless of whether it is being repeated or may not even make sense. To help an individual with dementia follow instructions, make certain to break each task into simple steps. Say only 1 or 2 steps at a time, or the individual will just not remember what was said. People who speak English as a second language may also forget it as their disease progresses. As memory of language is destroyed, many people will remember and understand only their native language, if that. Always show nonverbal signs of acceptance, caring, and validation. Individuals with dementia will usually understand those nonverbal behaviors, even if they do not understand the verbal language. So some nonverbal indications of caring could be a smile, patting their shoulder, or the nodding of your head to encourage trust. So dementia causes memory loss, disorientation, and problems with planning and problem solving, making it difficult for the person to recognize dangers or make sound decisions. Safety is crucial when working with someone who has dementia because the disease progressively impairs cognitive and physical functions, increasing their vulnerability to injuries and confusion. Safety measures to prevent falls, accidents, and wandering, allowing the person with dementia to maintain independence and dignity longer in a secure environment. Ensure individuals have their assistive devices, such as a walker or cane, for ambulation purposes. If they forget their cane or walker, you will need to give them their device and calmly remind them to use it. When possible, provide a large room or area, this safe space, where individuals can wander without the possibility of getting out of the building or entering other people's rooms. Make sure to remove any fall hazards from areas where individuals tend to wander, and keep individuals in sight. And make sure to protect the skin of wanderers. Prolonged periods of movement can cause clothes and shoes to rub the skin, so make certain that individuals who walk or move around a lot have uncomfortable, non-restrictive clothing and well-fitting, safe footwear. Daily check the feet and other areas of the skin for redness, bruises, blisters, or other signs of damage. Looking at some general strategies, the need for food or fluids may be the cause for behaviors. Feelings such as hunger, needing to use the bathroom, or just being bored cannot always be expressed verbally by individuals with dementia. Wandering is sometimes an attempt to find food, a bathroom, or just a response to being uncomfortable. If it is near time for a meal or the individual is not eating well, try giving food or making food visible for the individual to see. It is important to keep older persons well hydrated as well. So, individuals with dementia may not sense thirst or be able to interpret the feeling, so remind individuals to drink frequently. For those individuals who may not recognize a glass or remember how to pour fluids, those fluids will need to be poured and given to them. In some cases, wandering is an attempt to find a bathroom. Take the individual who tends to water to the bathroom at regular intervals and implement a toileting schedule with other staff to see if this reduces wandering. Wandering may be a response to the need for physical exercise. Provide exercise daily to allow individuals to satisfy the need for movement. This also has the added benefit of keeping them healthier and more mobile. Many individuals get bored when there are no activities and they're left on their own for long periods. Varied and structured activities throughout the day are likely to reduce wandering. Prevent boredom with simple tasks like folding towels, watering plants, or planting flowers. Providing simple tasks allows individuals to feel useful and reduces the likelihood they will devise their own forms of activities. Make certain that any activity provided, the individual is within his or her ability to actually perform. Complicated activities may lead to increase in frustration, anxiety, and undesirable behaviors. And remember, TV is not a structured activity. Television can also oftentimes be too stimulating for some individuals with dementia, particularly in the evening with that sundowning, and may even lead to agitated behaviors. Individuals who wander sometimes enter the rooms of others, that visiting. They may be looking for their own room or wishing to interact with others. Sometimes this leads to confrontations with other clients who feel this is an invasion of their privacy. Families of individuals may also be concerned. If an individual is infringing on the lives and privacy of others, try these strategies. So place pictures or familiar items outside rooms to help individuals find what they're looking for. Monitor individuals to keep them out of others' rooms, and validate any concerns they express, distract them from their current behavior, and redirect them if necessary. Find out why they're trying to go to these other places. So if they're looking for their room, the dining room, or if they're looking for a bathroom, try to figure out why this visiting is occurring. And some strategies when it comes to rummaging and hoarding. Try to find out, again, what they may be looking for. So they may not be able to tell you, but it is absolutely worth a try. Providing a rummaging room or area and directing the person to that area may absolutely work. Always keep valuables, so glasses, hearing aids, jewelry, or money, out of reach of rummagers. Monitor individuals who rummage closely and calmly redirect them to another area when they are entering others' rooms. Periodically check the rooms of individuals who are known to rummage and hoard items. This is necessary when someone's items are missing, but it's also important to the health and safety of the individual. Occasionally, food is hoarded and then will be spoiled. If individuals have not been monitored carefully when taking medications, they may spit out and hide their pills. We cannot always identify what needs are driving rummaging and hoarding, but individuals with dementia must be protected from adverse consequences of their behaviors. So some strategies to reduce or prevent sundowning. First, reduce the intake of drinks and foods with stimulants, things such as caffeine during the day, and do not give it in the evening or at night. So provide sufficient exercise and stimulating activities during the day. Discourage any long naps and keep active during the day so they're more likely to sleep at night. Provide structured activities at times the individual typically starts to wander. Reduce noise in the evenings, loud activities, any kind of televisions, and try playing soft music and adjusting lighting to reduce shadows. Use validation and redirection with the anxious and increasingly agitated individual. Loud noises, TVs, and very stimulating activities can result in escalation of agitated behaviors in the evening. While on the other hand, this soft and slow music has been shown to have a calming effect on persons with dementia. Wandering activities in some individuals is clearly aimed at getting out of the building. These clients are at risk for elopement, and they pose special challenges for staff even in locked areas. Safety devices may include things like alarms on doors, programmed door locks, window locks, and alarms attached to the client themselves. Visitors and staff must remain vigilant to individuals attempting to exit the unit when they open a door. Inform visitors not to let others exit with them unless they are certain the individual is not a client. Clients can wear identifying apparel or a bracelet. If your home allows, you can utilize a tracking device for individuals that are at risk of eloping. If individuals are still able to read signs or understand symbols, try attaching stop or do not enter signs to the doors. You can place dark tiles or paint in front of exit doors, which may deter individuals with dementia from exiting the door. Given visual and spatial problems that may accompany dementia, the individual may perceive the darkened area as a whole and not cross it. Disguising doors with paint, wallpaper, or a mural may also help. But if people are continually seen going in and out of the door, a disguise may not work. And always have a plan in place. All locations where dementia is present need to have a written and practice plan in place, so the case when a client elopes, we have it already practiced. Time is critical, and quick coordinated action may be the difference between life and death of a client. Remember, persons with dementia tend to move in the direction of their dominant hand, so search in that direction first. So make sure, though, that if there are greater dangers in another direction, such as busy roads, bodies of water, you do check those first, because safety is our #1 precaution. Most clients are found within a half mile from the location in which they eloped from. They tend not to respond if called to. The whole point was the elopement. They're not often willingly going to come back. They may head for roads or public transportation. They often hide in any available spot, maybe bushes, storm drains, empty buildings, or maybe even somewhere in the building itself. So some strategies for aggression. It is important to try to prevent physical aggression in individuals. This requires identifying and eliminating triggers whenever possible. A major thing to remember is to consciously move and speak more slowly. Know the history of the individual, so whether they have weakness on a specific side, anger, pain, have history of trauma. Keep your voice low, but within a range the person can hear. Remember, it takes the older adult more time to comprehend and respond to what you are saying. And in individuals with dementia, this problem is compounded. Prevention is the best strategy. Always explain what you are planning to do when caring for the individual, especially when completing their personal care. Be creative and go slow when communicating, so use pictures, gestures, and demonstrations with objects. Avoid appearing rushed or impatient. Put yourself in their shoes and try to relate to what the individual is experiencing and address their concern. Reduce the likelihood of agitation and aggressive behaviors during personal care activities by implementing these strategies. Have everything ready before starting the activity. Keep the individual warm and as covered as possible when bathing. Use clothes that are easy to put on. If the individual becomes agitated, stop the activity, speak to the individual in a calm, reassuring voice, back off, and give the individual time to calm down if necessary before starting the activity up again. Some other strategies can include pet therapy. So pet therapy can reduce aggression by fostering calmness and emotional regulation, promoting those positive emotions like joy, and providing a sense of control and responsibility. Well-trained, calm animals can have an amazing effect on behavioral symptoms in persons with dementia. They provide warmth and touch that many of the individuals need. It is not uncommon for even the most withdrawn individual to respond to an animal. Pets can also calm upset and agitated individuals. Maybe it can be helpful to integrate memories through art. So, for people with dementia, create personalized, hands on activities like collages, clay sculpting, or memory box decorating that use familiar objects and themes. Art allows individuals with dementia to express emotions, relive positive memories, stimulate cognitive functioning, and connect with others in a social setting. And then music therapy. So, music is a powerful tool that can significantly benefit people with dementia by evoking memories, improving mood, and enhancing connection with others. Listening to familiar music, singing, and dancing can reduce agitation. Familiar music, especially from a person's younger years, can act as a backdoor to preserved memories, bringing people with advanced dementia back to their autobiographical self. Remember that video that we watched earlier in this presentation and how it can assist with behaviors and amnesia. Things to avoid when it comes to aggression. So please avoid standing within striking distance. Make sure to respect an individual's personal space. Avoid touching a physically aggressive individual when they are upset and agitated. They are in that fight or flight mode. If they feel they can't fight, they will then go into fight. And then this is not an ego battle. Do not argue with the individual. The time is about safety, not about being right or correcting. Make sure to reinforce any kind of calm and low speaking, calm voice and tones. Be aware of and learn the triggers of individuals. Assess for and identify any new triggers. And always remove other clients or potentially dangerous objects if necessary. And strategies for inappropriate behaviors. Inappropriate behaviors often have causes not associated with sexual intentions. Disrobing may indicate they are hot or the clothing is uncomfortable. If they disrobe in public, try adaptive clothing that makes disrobing more difficult. Touching the genital area may indicate there is itching or pain. Always be aware of and check for those underlying causes, such as an infection or clothing that is causing discomfort. If getting in bed with another person uninvited, this is usually done for human contact and companionship. Remember, many of your clients may have slept with another person for much of their lives. Rarely is there an attempt to have sexual intercourse, but the possibility does exist. Just quietly remove the client and return them to their own bed. Remind them of boundaries, especially if this is an early stage dementia individual, but do not scold or berate. Again, they're not choosing to have the damage done to their brain. Urinating in public often results from the individual not being able to distinguish other objects from a toilet. In the case of people who worked outside most of their lives, it may also have been a common practice to urinate in places outside of a bathroom. Usually, this behavior can be reduced with more frequent toileting and close observation. Fondling and pleasing oneself may be an indication of sexual needs. People with dementia may still have an interest in sex and is often driven by biological needs that the client can no longer control. Occasionally, certain medications can also heighten this need. Taking the person to their room and allowing privacy is one solution. If the problem becomes difficult to manage, there are medications that can lower sexual drive. This does need to be used as a last resort. Some individuals with dementia maintain an interest and capacity for sexual intercourse. Married couples should be given the privacy to maintain intimate relations if both consent. In individuals who are not married or may have forgotten that they are married and develop a relationship with another client, issues of sexual behavior become more complicated. It is important to look into further policy and always refer to your supervisor for best practice. It may be helpful to distract and redirect to provide more activities to keep the person occupied. However, be mindful of the individual's personal rights. Working with a client who attempts to inappropriately touch you is difficult, but should be handled with a professional demeanor. If you encounter a situation where a client attempts to touch you inappropriately, do not scold or berate the client. Try to figure out what triggered that behavior. Calmly and firmly tell the client that that behavior is not appropriate and move away. If it consistently occurs when you are doing personal care, have someone else assigned to that care. The gender of the person assigned may need to be taken into consideration, as well as the client's sexual preferences. Diverting and redirecting the individual to other activities may reduce unwanted behaviors. These behaviors may indicate a need for reassurance from human touch. It may help to give these individuals appropriate physical contact when they are not displaying unwanted behavior. Holding a hand, a hug of the shoulders, gently rubbing their back may give reassurance without eliciting an unwanted response. Remember, these behaviors are often not intended as sexual by the person with dementia. These are some general rules that should be followed to reduce the likelihood of behavioral symptoms among individuals. Make sure to develop and maintain a simple daily routine. Be aware that there can be changes and inconsistencies in the individual's wants and abilities. Keep the environment calm, comfortable, and home-like with familiar possessions. Correct any kind of sensory deficits, such as using hearing aids, eyeglasses, and dentures. Use distraction to divert the individual from precipitating events. Also try to modify triggering events. Validate what the person is saying by acknowledging and the feeling behind the verbalization. And behavior is always communication. Their behavior is telling us something's not right. This is a warning. Pay attention. Do something to help me. And always remember, the person is not the problem. The problem is that there is an unmet need, or the person is trying to communicate their feelings in the only way they know how to in that moment. All right, that is all that I have for you in this training. If you have any questions or concerns, do not hesitate to watch this video again or refer to your supervisor for further information. Otherwise, have a great day.